We both feel strongly about our MIGS devices.
Yeah.
Where do you think the need is for our glaucoma patients?
I think the first premise is, should we consider doing something for more than just cataract surgery? And I think that's, the essence of where MIGS started. We think of ourselves as cataract surgeons.
Yeah.
We don't think of ourselves as glaucoma surgeons. Now that most glaucoma surgery often is not that high, intensity surgery, shouldn't we be reconfiguring that and thinking of ourselves as, cataract surgeons, but also as glaucoma surgeons? And maybe that's provocative to say that, but maybe that changes the mindset a little bit,
Like you say, we're ESCRS, it's a cataract and refractive society meeting. This is not a glaucoma meeting, yet glaucoma is everywhere.
Kind of like this meeting called it cataract and refractive surgery. And the merger of refractive and cataract surgery has been beautiful. We've seen the benefit of that. And I think we've got to apply that kind of logic perhaps to glaucoma. I think that we, just going into a patient, let's not focus on let's focus on, hey, you have glaucoma and happen to have a cataract, rather than the other way around.
The fact that we're at a European Cataract Surgery Society, is 15,000 people here, and we're talking about MIGS, that's a good thing.
It's a good thing.
That's a good thing.
So let's talk about maybe like the technology, because, obviously there's a lot of options out there. And what is the best way to approach enhancing outflow, which is what we're doing here?
I think that's what canaloplasty is like. It's cleaning out the gutter and cleaning out the natural drainage system. I like the idea of naturally restoring outflow. I like the idea of it being done early in the disease process, your interventional mindset.
Yeah, and it leaves the door open for other options as you choose to go more forward. The correlation between optic neuropathy and trabeculopathy, we can call it that, is not necessarily direct, but I think there's probably something in there, chronicity of things. So, I mean, the higher the med burden, the more advanced disease, I'm more apt to probably cut. Practically speaking, how do we get this into the hands of cataract surgeons?
Yeah, you're right.
For a cataract surgeon, on the other hand, who's dealing with milder cases, 1 or 2 meds, I think that canaloplasty alone can be quite reasonable.
And that's why it fits with cataract. You're already taking the risk intraocularly. You're already opening up the low risk of endophthalmitis. So the cataract plus argument is an easy one, and it's flattering to the pressure. We all know the phaco effect. That's studied to high heaven. We know that if we stent, we get some localized increase in outflow. But I do like going 360. I like the idea of going 360. It seems greater than 2 focal areas.
What have you seen some pearls as far as just getting that adoption curve over it?
I think choose the right eye. Some devices out there that you don't get any feedback, you're in the right place. So those that go through, I like the idea of a device that you can literally see slide around. You physically can feel it and see it. You've hit Schlemm's canal. But it's the same pearls we do every time. Gonio skills are vital. Do the MIGS device first if you're happy with it. When the cornea is clear and the view is better.
And I love your stuff talking about where you enter. Be careful not to go too posterior, because we're angling more anteriorly to posterior, parallax and stuff. So I think that's all.
I think that's less important in devices like OMNI, where you can see the guy where I go in. You're in the right place. You think.
Yeah, well, I mean, when you enter, if you enter to posteriorly, it could be problematic.
Yeah.
So I think just bias a little bit there and enter into.
And I think you realize the eyes are, it's a concave structure. You have to angle the tip up to get it in.
In the US, probably majority of patients have at least a discussion of MIGS, I would say, given everybody has it. I think in Europe it's a little bit different for different reasons.
I think it varies across European countries rather than Europe as a whole. Yeah. In the UK, we're getting towards most patients at least discussing phaco plus as an option. And I think that's what we should all be aiming for. But we've also got this 2-tier system where bigger hospitals do the complex work, and a lot of cataract is being done externally without the added option of MIGS, and that frustrates me somewhat.
What do you see as the barriers in terms of getting that up to par as far as what we think patients should have access to?
I think it's always going to be difficult, because we're always going to have cataract surgeons that don't do MIGS, and some glaucoma surgeons that don't even do cataracts. A lot of us are in the middle. But no, in the UK, if you want to do glaucoma training to what we call level 4, so a fellowship level training, you have to do cataract as well. So you can't do one without the other. Yeah. But that's not the same across Europe. I think you're never going to crush the whole landscape. But I think it's just training. It's days like this, it's videos like this that help people know these MIGS devices are out there. And we're really fortunate there's so many devices around for us. We can all find our favorite.
Right.